Page 729, review of blood pressure control. Everyone there? All right. So the blood pressure in the cardiovascular system is determined by 3 elements: the heart rate, the stroke volume, and the peripheral resistance. You guys be down here. Let's go to the baroreceptors. Take a look at this. As blood leaves the left ventricle of the aorta, it influences specialized cells in the arc of the aorta called baroreceptors. If there's sufficient pressure in those vessels, the baroreceptors are stimulated, sending that information to the brain. If the pressure falls, the stimulation of the baroreceptors falls off, and that information is also sent to the brain. So all of this to say that the brain sends signals to those baroreceptors that also affects blood pressure. Page 731. We're starting with hypertension. All right, of people with hypertension, 90%. So most people have what's known as essential hypertension or hypertension with no known cause. The underlying danger of hypertension of any type is the prolonged force on the vessel of the vascular system. Remember, guys, I told you all blood pressure is the amount of force that's being exerted against the vessel walls. Well, there's a danger if there is a lot of force for a long time. Let's take a look. The muscles in the arterial system eventually thicken, leading to a loss of responsiveness in the system. So that means if that person's blood pressure, there's a lot of force being exerted against those vessel walls for a prolonged amount of time. Remember, your body tries to survive no matter what. Remember when I stood up there and I showed you what can happen if that blood pressure becomes too high, how that vessel can just burst open, person can have a stroke, right? Your body's going to try to survive no matter what. So after being exposed to hypertension for an extended amount of time, what your body's going to try to do is protect yourself from that vessel bursting open. And so those vessel walls start to what? Thicken. Right here, look what it says. It starts to thicken. It's trying to prevent that vessel from bursting open. Here's the problem. That thickening of the vessels, number one, it decreases the responsiveness. Remember how your body will respond to low blood pressure. If the blood pressure is low, those vessels will start to contract to bring up the blood pressure. And if the blood pressure is high, those vessels will dilate, right? That's what's supposed to happen. But when your vessels start to thicken, because it's trying to protect yourself, because it's been exposed to the high blood pressure for so long, when it starts to thicken, it doesn't respond as well to those changes in blood pressure. That's number one. And the second problem with the vessel thickening is what I showed you when I stood up there on the board. Remember that a vessel being thick, there's not enough room for that blood pressure, for the blood to flow through. So that also increases the blood pressure. So in your body trying to protect you is also causing the problem. Does that make sense? All right. The muscles in the arterial system eventually thicken, leading to a loss of responsiveness in the system. The left ventricle thickens because the muscle must constantly work hard to expel blood at a greater force. So it's just your body's way of trying to compensate. Untreated hypertension increases the person's risk for coronary artery disease and cardiac death, stroke, renal failure, and loss of vision. This looks like a beautiful select all that applies to me. Think about it, guys. First of all, let's go back, because let me tell you something. When you're reading, when you're studying, do not read just to read. You have to understand what the author's saying to you. If you don't read it again, break it down. Look at what it says. Untreated hypertension increases a person's risk for coronary artery disease. What is coronary artery disease? Well, the coronary arteries, those are the vessels that bring oxygenated blood, vitamins, nutrients, minerals to the heart itself. So it only makes sense if the person has coronary artery disease, that vessel that's supposed to be feeding the heart muscle itself is sick, is diseased, is not able to feed the heart muscle effectively the way it should. So having untreated hypertension can cause coronary artery disease. Now we know what that is. It can cause cardiac death, where those heart cells actually die. Guess what, guys? Heart cells, brain cells don't regenerate. Once it's gone, it's gone. It can lead to stroke. I gave you an example when I stood up there. That vessel just burst, right? Renal failure. The kidneys stop working. They stop filtering the toxins out of your blood. They stop producing urine. And loss of vision. Guess what? Even your eyeballs have tiny little vessels. If your eyeballs are not perfused, guess what you think is going to happen? You're going to have decreased vision. You can even go blind. Important for you guys to know. Because hypertension has no symptoms, it's difficult to diagnose and treat. And that's why hypertension is known as a silent killer. Most people don't even know that they have hypertension until they have their first stroke. Thousands, hundreds of thousands of people are walking around and they are ticking time bombs. They don't even know that they have hypertension until they have their first stroke. Okay, that's why it's known as the silent killer. When you go to Publix or CVS or Walgreens and you see that little machine, it's free. Take your blood pressure every once in a while. Go get your annual physical and make sure that your blood pressure is under control. Remember, guys, we want that blood pressure to be 90/60, 140/90, right? Unless your textbook says different. I think this textbook is still 140/90, but we're going to get there. The numbers may differ. All right, factors that are known to increase blood pressure in some people include high levels of psychological stress, exposure to high frequency noise, high salt diet, and that makes sense because the more salt you hold on to, the more fluid you hold on to. The more fluid you have, the more pressure against the walls. The more pressure against the walls, the higher your blood pressure. So that makes sense. Lack of rest and genetic predisposition. That is that has been seen as a select all that applies on NCLEX. You better know that. So let's take a look at box 43.1. Oh, here we go. I knew it would be too far away. So normal blood pressure, systolic less than 120, diastolic less than 80. Okay, so according to your book, the stage 1 hypertension, guys, once you hit 130 to 139, over 80 to 89, that's stage 1 hypertension. So I suggest you know the normal and your stage 1. Normal, less than 120 over 80. Stage 1, 130 to 139, over 80 to 89. Let's take a look over here. If a patient has stage 1 hypertension, that's your 130 to 139 over 80 to 89. If they have stage 1 hypertension and they have high cardiovascular risk, we're going to talk about those risks, but those risks include obesity, high cholesterol. I'll go over those in a second. But if they have, if they're hypertension type 1 and they have cardiovascular risk, it's recommended that a medication to treat blood pressure is started. It is recommended that all people with stage 2 be started on medication. So if you're stage 1, 130 over 139 to 80 over 89, you're that stage 1, and you also have those cardiovascular risks, then it's recommended that the patient be treated. Yes.
So I was talking to my grandma. We're having like a debate on if people are put on blood pressure medications, they have to be on it for the rest of their life.
Absolutely not.
No, as long as they fix like their dietary
yes.
and their lifestyle
yes.
and stuff like that.
Yes, absolutely not. Most patients, they change their lifestyle and they can get that cholesterol under control. They definitely can get that blood pressure under control, and they can get off of the meds. They don't have, just because you're on hypertensive meds doesn't mean you have to be on it for the rest of your life. Okay. So now let's look at the second part. Everyone Anyone that is stage 2 hypertension, they absolutely have to be on meds. It doesn't matter their cardiovascular risk. So look at this stage 2. If it's more than 140 over 90, boom, they got to be on meds. Okay? Treatment guidelines, take a look. This is important, guys. Non-Black patients, including diabetic patients, may initiate treatment with thiazide diuretic, calcium channel blockers, ACE inhibitors, or ARBs. And remember, guys, they usually are going to start them on the thiazide diuretics, but they can start them on any of them if they're not Black. Black patients, including diabetic patients, may initiate treatment with thiazide or thiazide-like diuretic or calcium channel blockers. Look at this, before ACE inhibitors or ARBs due to better effectiveness. Study after study after study have shown these ACEs and ARBs, number one, they're not as effective in Black patients, and number two, there are more adverse effects in Black patients than non-Black patients. So that's why they start them, if they're Black, they start them on the thiazide diuretics. Okay? Patients, you know why? Like, it has to do on like that DNA link, like there's one tiny little thing on their DNA that others don't have, and that's what caused it. I'm not a geneticist, so I can't speak specifically, but I do know, like they know. It's something that has to do with their DNA that people of African descent have that other races don't. Patients 18 years or older with chronic kidney disease should initiate treatment with an ACE or an ARB. So this is important, guys. So if you're non-Black, they're giving you the list that they'll start you on. It could be thiazide, it could be calcium channel blocker, it could be ACE, it could be ARBs. But if you're Black, you expect the physician to order a thiazide or a calcium channel blocker before they ever try an ACE or ARB. But if you have chronic kidney disease, look at what they expect you initiated with, an ACE or ARB. And the reason we're going to get into that, but those ACE and those ARBs also have, they help with the kidneys. So that's why if the patient has chronic kidney disease, they'll put them on the ACE or ARBs. So you guys absolutely need to know this. Yes.
So then the only time where you would start a Black person on the ACE, oh wait, no,
Question. If you're 18 and you have, if you're 18, you're Black and you have chronic kidney disease, what do they give you?
They'll do the ACE or ARB, but they'll monitor you closely. All right. An ACE inhibitor or an ARB should, guys, look at this, should not be used together in the same patient. It's one or the other. Either they get an ACE inhibitor or an ARB. They are not going to get it together. If the goal blood pressure cannot be reached using only the drugs recommended, or a contraindication, or the need to use more than 3 drugs to reach a goal blood pressure, you're going to refer, that patient will be referred to a hypertension specialist. So if, you know, the nurse practitioner, the physician, the PA, the primary care doctor cannot get that blood pressure under control, they're going to refer them to a specialist. All right, look at box 43.2, white coat hypertension. This is important. You guys have to know this. Lots of people, their blood pressure will be fine until they go to the doctor's office and they see this white coat, right? Then all of a sudden their blood pressure is taken and it's through the roof, but it's really through the roof because they're nervous, they're at the doctor's office, they're scared. So it's important that these patients are taught to keep a blood pressure journal or diary at home. Take your blood pressure once or twice a day, mark down the time that you took it and what the blood pressure was, and kind of, you know, what you did before if that blood pressure is high. American Heart Association has put forth new guidelines for the diagnosis of hypertension. A patient should have at least 2 consecutive blood pressure readings above normal when taken by a nurse or trained technician over a period of 2 to 3 weeks. Whoever is taking the blood pressure should attempt to have the person relax before the assessment, because we want to make sure that this is a true reading and not just because they're nervous being in the doctor's office. It's good practice to periodically review process for performing this routine task. That's taking the blood pressure. Important things. Select a cuff that is the correct size for the patient's arm. You need to know this. If the cuff is too small, the blood pressure is going to be high, falsely high. And if the blood pressure cuff is too large, it's going to be falsely low. So you have to make sure that the blood pressure cuff fits the patient. Try to put that patient at ease. Talk to them for a minute, okay? Try to get them to relax. Ensure that the arm will be supported, ensure that the arm that will be used for the cuff is supported. It's not just hanging down, it's just sitting, it can be sitting on the arm of the chair, but make sure it's supported. Make sure that the rest of the patient's muscles are not tense while the blood pressure is being taken. And you guys can take a look at the rest. Let's look at cultural considerations. Antihypertensive therapy. African Americans are at the highest risk for developing hypertension, with men more likely than women to develop the disease. So Blacks are at highest risk than any other race, guys. And when it comes to gender, the risk is higher in the men than the women. African Americans have documented differences in response to antihypertensive therapy. For example, African Americans are most responsive to single drug therapy as opposed to combination drug regimens. Single drug therapy, and usually it's the thiazide diuretic, it's much more effective in African Americans than putting them on 2 or 3 different medications. They're more responsive to diuretics, calcium channel blockers, and alpha adrenergic blockers. Notice there's no ARBs or ACE inhibitors anywhere here when we're talking about the African Americans. Look at this. African Americans are less responsive to ACE inhibitors, ARBs, renin inhibitors, and beta blockers. That's been seen on NCLEX many times. Screening for hypertension among African Americans is important for detecting hypertension early. Because African Americans are more responsive to diuretics, they said this to us in the paragraph before, now they're saying it to us again, so we don't forget that they're more responsive to diuretics. The treatment approach should include the first line use of a diuretic in combination with diet and other lifestyle changes. And that first line, guys, is going to be thiazide diuretic. If we're talking about thiazide, we're talking about diuretics for African Americans, the thiazide is the first line. So we're going to put that, we expect them to be put on thiazide diuretics on top of lifestyle changes, such as more fruits and vegetables, and decrease or avoiding the fatty foods, the fried foods, teaching them to exercise and move around more, right? Key points. The heart rate, stroke volume, and peripheral vascular resistance are factors that determine blood pressure. A decrease in the blood flow to the kidneys triggers the RAAS, that renin, angiotensin, aldosterone system. Remember we talked about that? A decrease in blood flow to the kidneys, that's what triggers it. So if you get a question asking you, increased perfusion or decreased perfusion, which one triggers it? Decreased. By which the blood vessels constrict and water is retained. This activity increases the blood pressure and restores blood flow to the kidney. Hypertension is a sustained state of higher than normal blood pressure, and it can lead to vessel damage, atherosclerosis, and damage to small vessels and organs. The cause of essential hypertension, guys, is unknown. All right, page 735. Everyone there? Okay, we're going to talk about the RAAS, the renin, angiotensin, aldosterone system. Does this kick in when blood pressure is low or blood pressure is high? Low, very good. Write this down for you. Okay. The RAAS, renin, angiotensin, aldosterone system, is one of the body's main reflexes for maintaining blood pressure. In the absence of a known cause for hypertension, one approach to lowering the blood pressure is to affect the reflexes that control blood pressure. 3 classes of drugs have been developed in the is that wrong? I lied to you guys. Let's back it up. Let's back it up. I lied to you. Is everyone listening? Because I'm reading. I completely lied to you. So just wipe this out. Pretend like I never said that. Everyone with me? This kicks in when the blood pressure is high. I'm so sorry. I'm human. Kicks in when blood pressure is high. The ACE inhibitors, which block, we went over all of this, which blocks the conversion of angiotensin 1 to angiotensin 2, ARBs, which block the angiotensin receptor site on the blood vessel, and renin inhibitor, which blocks the reflex at the beginning by inhibiting renin. You guys do have to know these actions, okay? Your ACE inhibitors, your ARBs, your renin inhibitors, it's right here, it tells you what they do. Let's jump to page 739. Wait, before we jump to page 739, because I don't want anyone coming back after the exam, let's make sure we're all clear on this. Everyone, the renin angiotensin aldosterone system, it kicks in when blood pressure is what? High. Okay, great. All right, page 739. Let's take a look at this. Step care management of hypertension. Was I?
Yeah.
I'll be so mad at myself. Let me go back and read this. The RAAS is one of the in the absence of known cause for hypertension, one approach to lowering blood pressure is to affect the reflexes that control the blood pressure levels. 3 classes of drugs have been developed to alter as, wait, let me stop. So it alters as, that means, wait, guys, I have to think, please, don't say anything. Let me think for a second. Alters the RAAS. So the RAAS kicks in when the blood pressure is low, and if they alter the RAAS to make that blood pressure go high. No, I'm lying. Am I right? No, guys, I have to think about this. Give me 2 seconds. This is how my brain works. Give me a second. They alter the RAAS, bring down the blood pressure. So the RAAS should kick in when the blood pressure is high. Let's go back.
Page 7.
Because I'm having a complete brain fart. Page
723.
Drop in blood pressure.
723.
Google says drop in blood pressure.
So I was right the first time.
Yes.
I'm getting a second shot of this from now on. You want to know what's so sad? I literally just went over this with you guys like 10-15 minutes ago. I know, but I know better. It's one of those days. I'm sorry. Everyone come back to this page because I got to make sure everyone is on the same page with me. I was right the first time. I'm sorry. Don't change your answer. Don't doubt yourself. All right. So let's make sure that we're all clear. I'm so sorry. You guys forgive me?
Yes.
Okay, thank you.
Forgive you when I get it wrong on the test. And you give me credit.
Okay, so let's clear this up. So that RAAS, the renin angiotensin aldosterone system, it kicks in when blood pressure is low, right? This is true. We all understand it kicks in when blood pressure is low. But these meds, what these meds do is alter it. It stops it to do the opposite. Does that make sense? So our ACE inhibitors, our ARBs, our renin inhibitors decrease the blood pressure. So let's go back. These drugs, the renin angiotensin aldosterone system, this whole system that kicks in when the blood pressure is low and then makes the blood pressure go up, these meds do the opposite. It brings that blood pressure back down. Does that make sense? Yes. So if I were to ask you a question, and let's say I said on the test that the renin angiotensin aldosterone system kicks in when the blood pressure is low and it increases the blood pressure. Would that be true or false? True. I need a confident true. True. If on a test I said to you that meds,
Like, yeah, can you repeat that? Just so we're.
you want me to repeat it? Okay. So if on an exam, I were to say that the renin-angiotensin-aldosterone system kicks in when the blood pressure is low to increase the blood pressure, would you write true or false? True. Because it does kick in when that blood pressure is low because the action is to bring that blood pressure up. If I were to say to you that medications such as the ACE inhibitors, the ARBs, and renin inhibitors, they alter RAAS, so RAAS doesn't function the way it's supposed to, so RAAS does not increase the blood pressure. These drugs would actually decrease the blood pressure. Would that be true or false? True. So we're on the same page. RAAS kicks in when the blood pressure is low to bring the blood pressure up, and our ACE inhibitors, our ARBs, all of these antihypertensive medications that we're talking about alter the RAAS to bring that blood pressure back down. Okay. All right, let's jump to page 739. And because this was such an ordeal, you guys already know this, I'm definitely going to make test question. I'm going to make this 2 test questions for you, okay? All right, moving on. Box 43.7. Everyone there? All right, step care management for hypertension. What do we do when our patient's hypertensive? We always try to do a step up approach. Some patients we can't because the blood pressure is so high. Remember, if they're hypertension 2, they have to go on meds, right? But let's say if they're hypertensive 2, they have to go on meds, but we're still going to teach them lifestyle modification. Everyone is going to be taught lifestyle modification, but the goal is to get them to do lifestyle modification so we don't have to go to meds. Does that make sense? In nursing and medicine, we always try to go from least invasive, least severe to more. So we're going to first teach lifestyle modifications. What are those? You have to know them. I promise they're going to be on your test. Lose weight. Stop smoking. Moderation of alcohol. So we don't tell you stop drinking alcohol the way we tell you to stop smoking, but we tell you, just drink a little bit, drink in moderation. Don't be a heavy drinker. Reduction of salt in diet. We don't tell you to avoid salt. We don't tell you to stop having salt completely, but we tell you to reduce it severely. Increase in aerobic physical activity. Get moving. Okay, those are the lifestyle modifications. Now, if that does not work, we're moving on to step 2. Step 2 is going to include everything we talked about in step 1, eat right, exercise, stop smoking. But in addition to that, we're going to teach them that they're going to need medicine. Diuretics, because remember, diuretics gets rid of fluid. You get rid of fluid, you're getting rid of fluid volume. You get rid of fluid volume, you get rid of pressure being exerted against the vessels. You get rid of pressure being exerted against the vessels, blood pressure goes down. So we're going to teach them either diuretics, ACE or ARBs. ACE or ARBs, ACE or ARBs, what type of patient is that going to not be the first line treatment for? African American, very good. Calcium channel blockers, angiotensin 2 receptor blockers. Notice, guys, you need, in parentheses, they tell you the action of the drugs. You need to know them. They have to be on your drug cards anyway. The diuretics, they decrease the serum sodium levels and blood volume. Your ACE inhibitors, they block conversion of angiotensin 1 to angiotensin 2. Calcium channel blocker, they relax muscle contraction, and ACE, ARBs, your angiotensin 2 receptor blocker, they block the effects of angiotensin on the blood vessel. Let's say that doesn't work. So Step 1, teaching them lifestyle modification. Step 2, they were getting either diuretics, ACE, ARBs, calcium channel blockers. That didn't work. Step 3, consider change in drug dose or class or addition of another drug for combined effect. We expect the physician or the PA or the nurse practitioner to do this, but this is what you should expect from them as a nurse. And remember, this is great, step 3, but not for African Americans, because we know one single drug is more effective for African Americans. Remember that. Step 4, again, all of the above are going to be continued, and then second or third agent or diuretic is added if not already prescribed. That doesn't work. Guess what? They have to be punted to a specialist. We don't know what to tell you. So make sure you guys know box 43.7. You guys are going to get questions from this box. All right, let's talk about the ACE inhibitors. ACE inhibitors, those are one of your drug cards that you're going to show me next week. Make sure you have all of those drugs on there, but notice that those ACE inhibitors end in PRIL, P-R-I-L. Therapeutic actions. ACE inhibitors act on the lungs to prevent ACE from converting angiotensin 1 to angiotensin 2, a powerful vasoconstrictor and stimulator of aldosterone release. This action leads to a decrease in blood pressure and in aldosterone secretion, with a resultant slight increase in serum potassium and loss of sodium and fluid. So that's important. Don't skip over what it's saying, guys. So look how the ACE inhibitors bring down the blood pressure. You have a decrease in blood pressure and aldosterone secretion, but it also causes a slight increase in potassium, and you're going to have a loss of sodium and fluid. And that makes sense. First of all, you guys know that sodium and potassium go the opposite way. So us getting that patient getting rid of that sodium, you know they're going to get rid of the fluid because the fluid follows sodium. But something you got to keep in mind, we're getting rid of that sodium, but what is slightly increased? The potassium. Remember, remember, potassium has a very narrow therapeutic range. What's the therapeutic range of potassium? 3.5 to 5. So if the doctor were to order an ACE inhibitor for a patient that's hypertensive and you're looking at the labs and you see that potassium 5, are you going to blindly give that med, or are you going to hold it and call the doctor? Hold it and call. This is how you need to be thinking as a student while you're reading, guys, because they're not coming straight out and telling you what I just said to you, but some kind of flag should go off in your brain when you see there's a slight increase of potassium, and you've learned the potassium has a very narrow therapeutic range, and you learn the potassium can kill you. That's how we kill inmates in the state of Florida when they're on death row, right? All right, pharmacokinetics. All of the ACE inhibitors are administered how? Orally. They're never injected. They're given orally. Contraindications and cautions. Obviously, if the patient has any allergy to ACE inhibitors, if they have impaired renal function, because if the kidneys aren't working, they're going to be holding on to that medication longer. If they're in heart failure, look at this. Women of childbearing age who choose to use one of these drugs should be encouraged to use barrier contraceptives to avoid pregnancy while taking the drug. Use is contradicted during pregnancy. So if the woman's of childbearing age, what's the barrier they're talking about? What do they need to be using? Condoms, very good. Adverse effects. The adverse effects are related to vasodilation and alteration in the blood flow. Such effects include reflex tachycardia, that heart rate going up, chest pain, angina, heart failure, hence why if a patient already has heart failure, that's going to be contraindicated, because look, heart failure is an adverse effect. Cardiac arrhythmias, GI irritation, ulcers, constipation, liver injury, renal insufficiency, renal failure, proteinuria. Are we ever supposed to have protein in the urine? You see protein in the urine, you know those kidneys are in trouble. Rash, alopecia, dermatitis, photosensitivity. ACE inhibitors are generally well tolerated, but can cause an unrelenting, which means it does not go away. It's horrible. Unrelenting Non-productive cough. And then on the side, I wrote here, especially in blacks. If a patient has just been prescribed an ACE inhibitor and, a week later they come in, they're like, I have a cold. And you're asking, well, what's going on? They say, well, I have this cough that just won't go away. Do you think, and there's no other symptoms, there's no congestion, nothing else. Do you think that patient really has a cold? No, most likely they have this cough that's an adverse effect of the ACE inhibitor. Captopril, Misopril, Prendopril are associated with more serious adverse effects. Captopril has been associated with sometimes fatal pancytopenia. Let's talk about this, guys. Don't just read a word and not know what it means. Pan, covering everything. Cyto, cells. Penia, little bit of. So pancytopenia is when the patient doesn't have enough of all of those blood cells. Those RBCs are decreased. Those platelets are decreased. Those WBCs are decreased, okay? So it can cause pancytopenia. Let's stop, and before I keep going, I know I'm being annoying, guys, but I'm trying to teach you how to study because you only have me for a semester. Next semester, you're on your own. Let's think about this. All right, Professor D said RBCs decrease. Okay, so what? Hello? What does RBC carry? Hemoglobin. What does hemoglobin carry? Oxygen. So that can cause severe anemia in the person. Decreased WBCs. What do WBCs fight? Infection. Patients at risk for infection. Hello? Platelets. If platelets are decreased, platelets help you clot, keeps you from bleeding out. So the platelets are decreased, that patient's at risk for internal bleeding, for hemorrhaging. So of course, absolutely, it's life-threatening. Yes, ma'am.
For the adverse effect for coughing, is there anything that you can do for that?
They'll switch them to another medication. Because look at what it says. The cough is what? Not even non-productive. That's not the, it's unrelenting, which means no matter what you do, it does not stop. Captopril has been associated with sometimes fatal pancytopenia, decreased RBC, decreased WBC, decreased platelet. It's also been associated with cough, unpleasant GI distress. Moexapril has been associated with many of unpleasant GI and skin effects, cough, cardiac arrhythmias. Fatal myocardial infarction and pancytopenia has sometimes been associated with that drug as well. How do I pronounce this drug? Perindopril. You guys see it. Perindopril and lisinopril are associated with sometimes fatal pancytopenia, as well as serious to fatal airway obstruction found to occur more frequently in who? African Americans. And so what we find with the ACE inhibitor, especially in African Americans, it can cause angioedema. Their tongue swells up, it includes the airway, or closing even of the airway. We see that often in African Americans. That's why we stay away from giving that to them. Okay? Drug-drug interactions. The risk of hypersensitivity reaction increases if these drugs are taken with allopurinol. Well, we haven't done gout yet, so you wouldn't know what that drug is. Well, now you do know, okay? There is a risk of decreased antihypertensive effects if taken with NSAIDs. So wow, that's important for us to know, because if we're giving ACE inhibitors to a patient because we couldn't get their blood pressure controlled, so now we're trying to get their blood pressure controlled. That's why they got an ACE inhibitor. That's important to know, that if we give them an NSAID, that might make the ACE inhibitor not work the way it's supposed to, so we won't be able to control the blood pressure. Don't you think that's important to know? Very important. Drug-food interaction. ACE inhibitors decreases if they're taken, absorption of oral ACE inhibitors decreases if they're taken with food. They should be taken on an empty stomach an hour before or 2 hours after. Because if you're taking that ACE inhibitor with food, the absorption is not going to be as strong. Why? Because the food is competing for those receptors just like the medication is. So you want it on an empty stomach 1 hour before or 2 hours after meals. Nursing considerations for patients taking ACE inhibitors. You're going to assess them for allergy, kidney function, pregnancy, lactation. You're going to take their vitals, get a baseline. You're going to get you're going to take a CBC, because why? You want to see what those RBCs look like. You want to see what that hemoglobin look like, because there's chance of what? Pancytopenia, right? You want to see what those WBCs look like. You want to have a baseline. So if you see those numbers going down, you can say, uh-oh, I have to call the ordering prescriber and let them know what's going on. Encourage, oh, before I get down here, look at this one. Why would we want serum electrolytes? Because we know that the sodium will go down and the potassium will slightly increase. So we need a baseline, because our normal sodium is supposed to be 135 to 145. Bad things happen when that sodium becomes lower than 135. That patient becomes hyponatremic. So we're going to be watching out for those signs and symptoms. We know that this medication can cause a slight elevation of potassium, and we know potassium has a narrow therapeutic range, 3.5 to 5. So we need that baseline, and we need to keep looking at those labs to make sure it doesn't surpass the 5. Implementation and rationale. Again, teach them lifestyle changes, stop smoking, drinking, moderation, exercise. Teach them to lose weight, decrease sodium in the diet. As far as the ACE inhibitors are concerned, on an empty stomach, 1 hour before, 2 hours after meals. Alert the surgeon and mark the patient's chart prominently if the patient's to undergo surgery. Everybody needs to know that patient is on ACE inhibitors. Let me tell you something. It doesn't matter what type of surgery a patient has. We know this. If a patient has surgery, 3 of our top concerns for that patient coming from surgery are going to be hemorrhage, them developing a DVT or pulmonary embolism, or them developing an infection. Monitor the patient carefully in any situation that might lead to a drop in blood volume, because a drop in that blood volume is going to cause a drop in the blood pressure. And guys, just as much as hypertension is bad, hypotension is bad as well, because that's decreased perfusion to the tissues. So you're going to be watching out for these type of situations. Excessive sweating, they're losing fluid from that sweating. They're also losing sodium. Vomiting, diarrhea, dehydration. Think about it. If the patient has excessive sweating, or they got diarrhea, dehydration, whatever it is, and they're also taking an antihypertensive med, what do you think is going to happen? That patient's going to bottom out. You're going to find them on the floor. Okay? Provide comfort measures, teach them small, frequent meals, make sure they have access to bathrooms, especially if they're on these diuretics, bowel program. Environmental controls. Remember, one of the things that can cause the blood pressure to go up is what? Noise, excessive stimulation. So this type of patient, you're going to make sure that it's nice and quiet. There's not too much stimulation, anything to upset the patient. You're going to have safety precautions, because those antihypertensive meds might work a little bit too well. And now we threw that patient from hypertension to hypotension. All right, next, let's talk about ARBs. Angiotensin II receptor blockers. The ARBs selectively bind with angiotensin II receptors in vascular smooth muscle and in adrenal cortex to block vasoconstriction and the release of aldosterone. Remember, vasoconstriction will cause the blood pressure to go up. So if you block the vasoconstriction, you're blocking the ability of that blood pressure to go up. It makes sense. These actions block the blood pressure raising effects of the renin-angiotensin system and lower blood pressure. Pharmacokinetics, they also are only given orally. Contraindications and cautions: allergy, liver or hepatic dysfunction, hypovolemia. If the patient's blood pressure is already low, why would we give them an antihypertensive? That's why before you give that antihypertensive, you have to take their blood pressure. And if it's low, you're going to withhold the medication, call the prescriber. Other contraindications: pregnancy. Women of childbearing age, again, they need to wear barrier contraceptives to avoid pregnancy. If a pregnancy does occur, the patient has to discontinue that ARB immediately. They cannot be pregnant and taking an ARB. Adverse effects of the ARBs. Adverse effects most commonly associated with ARBs include headache, dizziness, syncope, weakness, which could be associated with the drop in blood pressure, hypotension, GI complaints, diarrhea, abdominal pain, nausea, dry mouth, tooth pain. I don't know why tooth pain, I have no clue. Symptoms of upper respiratory tract infections, cough, rash, dry skin, and alopecia. Drug-drug interactions. There's a loss of effectiveness of the ARBs when they're taken with phenobarbital, indomethacin, or rifamycin. There may be a decrease in anticipated antihypertensive effects if the drugs are combined with ketoconazole, fluconazole, or diltiazem. These drugs should not be used with ACE inhibitors or renin inhibitor because of the potential for serious adverse effects. You never give both an ACE or an ARB. The patient's going to get one or the other. If you ever see both of them prescribed, do not be a dummy nurse and give it to the patient. You're going to withhold both meds and call the prescriber for clarification. Considerations for patients taking ARBs. Again, you're going to assess them for allergies, kidney or liver dysfunction, pregnancy, lactation, hypovolemia, because we know along with hypovolemia comes low pressure against the vessels. Low pressure against the vessels, low what? Blood pressure. And do we ever give an antihypertensive to a patient that already has low blood pressure? No. So we're not going to give an antihypertensive to a patient that already has low blood volume. Everyone with me? Okay. You're going to take a baseline. Blood pressure, labs, everything. Implementation rationale. Encourage the patient to implement lifestyle changes. Lose weight, stop smoking, drink in moderation, decrease on diet, exercise. Alert the surgeon and mark the patient's chart prominently if the patient's to undergo surgery. Ensure that the female patient is not pregnant before beginning therapy. Before you give that ARB, you better check and make sure an HCG was done and that it was negative, because they cannot be pregnant taking this medication. If they're childbearing age, teach them that they absolutely must use a barrier method of contraception because they cannot be pregnant on this medication. Monitor them carefully for any situation that might lead to a drop in fluid volume, again, such as excessive sweating, vomiting, diarrhea, dehydration. Provide comfort measures. Next, calcium channel blockers. Calcium channel blockers decrease blood pressure, cardiac workload, and myocardial oxygen consumption. The effects of these drugs on cardiac workload also make them effective in the treatment of angina, that chest pain when the patient's not getting enough oxygen to the heart muscle. Therapeutic actions and indications of calcium channel blockers. They stop the movement of calcium ions across the membranes of myocardial and arterial muscle cells, altering the action potential and blocking muscle cell contraction. That's how it works. This effect depresses the myocardial contractility because it blocks that muscle cell contraction. It slows the cardiac impulse, and it relaxes and dilates the arteries, which causes a fall in the blood pressure and then a decrease in venous return. Contraindications and cautions of the calcium channel blockers. Heart block or sick sinus syndrome, which could be exacerbated by the conduction slowing effects of the drugs. Remember the action of the calcium channel blockers, how they work. So if the patient has a heart block or sick sinus syndrome, you're not going to give this med. Renal or hepatic dysfunction, pregnancy, again, if they're of childbearing age, they need to wear barrier contraception. If they're breastfeeding and they're on this med, they have to find another way of feeding that baby. Another method of feeding the infant should be used if these drugs are required during lactation. The mother cannot breastfeed on calcium channel blockers. Adverse effects. You guys see them, the CNS effects such as dizziness, headache, lightheadedness, GI effects, nausea, hepatic injury, cardiovascular effects, hypotension, bradycardia, peripheral edema, heart block, drug-drug interactions. A potentially serious effect to note with the calcium channel blockers, look at this, guys, is an increase in serum levels and toxicity of cyclosporine if taken with diltiazem. And you guys, we're about to learn about those drugs, I think, in the next chapter. Before I do food-drug interactions, let's take a look at this box up here, box 43.8. I know, I'm so sorry. This is heavy stuff. Several drugs that are used to treat hypertension cannot be cut, crushed, or chewed. Some antihypertensives to be aware of are diltiazem, isopropidine, nicardipine, nifedipine, those meds that end in pine, those are your calcium channel blockers, by the way. The Solidipine and verapamil. They can be cut, they can be chewed, they can be crushed. You guys see that? Okay. Moving on, food-drug interactions of the calcium channel blockers. Calcium channel blockers are a class of drugs that interact with grapefruit juice. The patient cannot have grapefruit juice when they're taking calcium channel blockers. When grapefruit juice is present in the body, the concentrations of calcium channel blockers increase, sometimes to toxic levels. Advise patients to avoid the use of grapefruit juice if they're taking a calcium channel blocker. They should not be having any grapefruit juice in their diet if they're taking a calcium channel blocker. If a patient on a calcium channel blocker reports toxic effects, ask whether he or she is drinking grapefruit juice. Page 746, they give you a situation about an African American that has to be on, let me see what they're on. What are they on? What was ordered for them? A calcium channel blocker. So look on page 747, what you're going to teach them. High blood pressure is a disorder that has no symptoms, but it can cause serious problems. Remember, hypertension, known as a silent killer. It can cause heart attack, stroke, kidney problems. You're going to teach them to take their medication every day, even if they're feeling good. They're still a ticking time bomb. Take it every day. Teach them that the drug should be taken on an empty stomach. Remember, 1 hour before, 2 hours after meals. Teach them about the common drug effects. I'm not going to go over them again. Make sure you guys take a look at this. We talked about that already. All right, let's move on to vasodilators. Before I move on to vasodilators, there's one more thing. What's all this breathing hard?
You're going a little fast.
I'm going too fast? Okay. A lot of this is repetitive though, but okay. Everything that I just went over with you on this right here, guys, all this stuff I went over already. It's just repeating itself. I'm on page 746, but this is where I'm going to lead you to. Let's jump to page 805. We're still talking about calcium channel blockers. Let's jump to page 805. I don't know why they did not put this where we were talking about calcium channel blockers. I have no idea. But here it is. So make a note when you're studying to jump to page 805 to look at the nursing considerations and the implementations for the calcium channel blockers. Everyone there, page 805. Everything we're about to look at, guys, we already saw in the book. We talked about it already. Remember, this is just a reminder. Okay. Again, patients taking calcium channel blocker. We are going to teach that patient. We're going to assess them actually for allergies. Make sure they're not allergic to the drug. Make sure they don't have liver or kidney dysfunction. Make sure they don't have heart block. That's a contraindication because remember, when it comes to the calcium channel blocker, heart block is an adverse reaction. So if the patient has heart block, why would we give this medication to them? Absolutely not. Another contraindication is them being pregnant or breastfeeding. They cannot get pregnant on this drug or breastfeed while they're taking calcium channel blocker. We're going to do a physical assessment on the patient. We're going to take vital signs. We're going to assess the patient. Look at this. Assess the patient for complaint of pain, including the onset, duration, intensity, and location, and the measures used to relieve pain. If the patient says that they have had chest pain, you need to find out, well, what kind of chest pain was it? Was it sharp? Was it shooting? Was it stabbing? Because all of this is what you're going to report to the nurse practitioner or the physician, all right? So you're going to find out quality. What type of pain was it? Was it pain between 1 and 10, 1 being the lowest, 10 being the worst? What level was the pain? When did the pain start? What were you doing when the pain started? What did you do when the pain stopped? Those are the type of questions you're going to be asking the patient. Investigate activity level prior to, before, and after the onset of the pain. You're going to assess the cardiopulmonary status closely, including their blood pressure, their heart rate, the rhythm. You're going to get an ECG as ordered. Monitor respirations. You're going to listen to the lungs. You're going to look at the lab results. Page 806. Again, you're going to take their blood pressure, cardiac rhythm, cardiac output, monitor their blood pressure carefully. Again, monitor blood pressure, cardiac rhythm, provide comfort measures. We've seen these comfort measures a million times. Small, frequent meals. Make sure environmental controls, dim lighting. Make sure there's not excessive interruptions because remember, psychological stress also increases blood pressure, right? Safety precautions. Make sure they have periodic rest time. Okay, now we're back to where we were, page 746. Vasodilators. Vasodilators.
Can you give me 1 second?
Sure. Vasodilators. If other drug therapies do not achieve the desired reduction in blood pressure, it's sometimes necessary to use a direct vasodilator. Let's stop right there. There's a reason that they worded it the way that they did. Look at what it says. If other drug therapies. That lets us know our vasodilators are not our first line drug treatments for hypertension. We're using other stuff first, and if none of those work, then we're going to try the vasodilators. Most of the vasodilators are reserved for use in severe hypertension. We have tried everything else, nothing is working, and if we don't get this blood pressure down, that patient's going to die. Okay? Most of the vasodilators are reserved for in severe hypertension, malignant hypertension, or hypertensive emergencies, all of which can kill the patient. These include, and they give you the list, make sure you know these vasodilators. I expect to see them on my drug cards next week. Therapeutic actions and indications. The vasodilators act directly on vascular smooth muscle to cause muscle relaxation, leading to vasodilation, and therefore drop in blood pressure. Excuse me. Thank you. They're indicated for the treatment of severe hypertension that has not responded to other treatments. So they've told us many times that this is not our first line, not even second line drug that we go to for hypertension. We go to the vasodilators when nothing else has worked. or their situation is so severe. Pharmacokinetics. Nitroprusside is used how? IV. So far, all of the drugs we talked about were PO, right? But we bringing out the big guns. IV. Hydralazine is available oral, IV, or IM. Minoxidil is available oral only. You need to know that. I really don't touch on the pharmacokinetics too often, but if I'm talking about it, that means it's been seen on NCLEX, ATI, HESI, or all three. You got to know it. Contraindications, cautions. Allergy to the drug. Any condition that could be exacerbated by a sudden fall in blood pressure, such as cerebral insufficiency. Anything that can really affect the patient with a sudden drop in blood pressure, because remember, these are the big guns. They don't work slowly. They're expected to bring down that blood pressure very quickly. So if a patient has a condition where a sudden drop in blood pressure can literally kill them, we can't give this to them, guys. An example is cerebral insufficiency. Caution should be used in patients with peripheral vascular disease, cardiac, coronary artery disease, heart failure, or tachycardia. Other contraindications and cautions, pregnancy. If they're needed by a nursing mother, another method of feeding the baby should be selected. You cannot breastfeed on this medication. They're going to have to find another way to feed the infant. Adverse effects. Dizziness, anxiety, headache, reflex tachycardia, heart failure, chest pain, edema, skin rash. Look at this, cyanide toxicity. Look at these symptoms of cyanide toxicity. Dyspnea, headache, vomiting, dizziness, ataxia. Ataxia is when they're walking like they're drunk, okay? Loss of consciousness, imperceptible pulse, can't even feel it. Absent reflexes, dilated pupils, pink color, distant heart sounds, shallow breathing may occur with nitroprusside.
Is it the skin that's the pink color?
Yes. Nursing considerations for vasodilators. You're going to assess the patient for any allergies, impaired kidney or liver function, pregnancy, lactation, cardiovascular disease. You're going to take a baseline status, you know, vital signs, labs, ECG as ordered. Implementation rationale. Again, lifestyle changes, lose weight, stop smoking, decrease alcohol, decrease sodium, start exercising, teach them to monitor their blood pressure regularly, monitor blood glucose and serum electrolytes, monitor the patient carefully in any situation that might lead to a drop in fluid volume. Again, excessive sweating, vomiting, diarrhea, dehydration, because this the vasodilator is going to drop that blood pressure quickly. Provide comfort measures such as small frequent meals, access to bathrooms. You're going to do safety precautions. All right, guys, we're going to stop here.